Hi there from Dartmouth. My name is Konstantinos Linos, and I would like to thank the International Society of Dermatopathology for inviting me to this virtual meeting. On my virtual background, you see the main library of Dartmouth University in New Hampshire, United States, where it's a beautiful piece of architecture. I have no financial disclosures, and this is the outline of a few immunohistochemical stains that I will be discussing. So start from a few vascular tumors. As you know, epithelial hemangioma can be subcategorized in conventional subtype, angiolymphoid hyperplasia with eosinophilia, or cellular subtype. And recent genetic findings have questioned if these subtypes actually are distinct entities or one entity. And this is a classic epithelioid hemangioma where you see it's very well circumscribed. It's surrounding big vessels. And if you go higher power and cytologic grounds, you see epithelioid cells with voluminous eosinophilic cytoplasm with no significant cytologic atypia or atypical mitotic figures. And you may see tons of eosinophils or lymphohistiocytic infiltrate, although this is by no means necessary to make the diagnosis. Of course, it's a vascular tumor, so it's going to be positive for vascular markers such as CD31, CD34, and ERG, and it's also positive for D240. The pitfall in general in vascular tumors, and actually specifically the more epithelioid they may actually be positive for EMA and keratin for focal to multifocal to a diffuse fashion, creating diagnostic difficulties to the people who are not familiar with these patterns. The recent genetic findings have shown rearrangements of FOSB and FOS genes, where are transcription factors with various partners, as you see here, WWTR1 and ZFP36 and 20% of cellular subtype, or other partners with FOS rearrangement in a high percent of cellular subtypes. And there are some clinical genotypic and morphological associations between FOS rearrangements that are more common in cellular and skeletal epithelial hemangioma and FOSB that are more common in more atypical epithelial hemangiomas. For example, the story with atypical epithelial hemangioma starts with the ZFP36 FOSB fusion, and these epithelial hemangiomas can show significant cytologic atypia, necrosis, and they have a propensity for some reason to penile location. So people may misdiagnose as epithelioid angiosarcomas, and you can imagine if you misdiagnose a totally benign epithelial hemangioma with atypical features for epithelial angiosarcoma in the pineal region, whether it be pretty significant treatment consequences. Subsequent papers found frequent FOS gene rearrangements in epithelial hemangioma in various anatomic locations. However, these are not that common in skin and head and neck locations. So if you don't have these rearrangements, you still can be an epithelial hemangioma, especially on cutaneous cases or head and neck cases. And there are immunohistochemical markers for FOSB, which is a rapid monoclonal antibody, and the less common is a FOS antibody, which is a polyclonal antibody and works pretty well when it works. This is a nice paper from Europe showing FOSB immunoreactivity in the endothelia of epithelial hemangiomas. This nice nuclear positivity with a kind of weak background, cytoplasmic and non-specific background. And this is another cavernous hemangioma-like epithelial hemangioma, if I may, which shows a nice diffuse positivity for FOSB. And of course, epithelial hemangiomas can be multiple and eruptive like other vascular tumors. And this another paper from Europe showed expression of FOSB in all the cases of multiple eruptive epithelioid hemangiomas. And again, nice, crisp nuclear immunoreactivity with a background of weak non-specific cytoplasm. So we're looking for nuclear immunoreactivity here. So in terms of sensitivity for FOSB immunohistochemical markers, it's about 75% in a conventional subtype, approximately 100% in angiolymphoid hyperplasia, and 10% of cellular subtype. However, these rearrangements and subsequent the immunohistochemistry is not that common in skin and head and neck cases. And this is a very recent paper showed recurrent GATA6 FOXO1 in a subset of epithelial hemangioma who had propensity for skin involvement or head and neck location. And all these cases were negative for FOS or FOSB immunoreactivity. Pseudomygenic hemangioenthilioma typically involves young adults with a marked male predilection, 4:1, which we're not sure why. And basically, it's a rare soft tissue neoplasm of intermediate biologic potential, meaning has a propensity for local recurrence and frequent and characteristic development of additional nodules in the same region in different planes, skin, subcutaneous, bone, etc. But metastasis is rare. There are some cases that can behave very aggressively, but that's not common, which is typical for mesenchymal neoplasms of intermediate biologic potential. And conservative treatment is the mainstay in therapy. And this is a classic case of pseudomyogenic hemangioenthilioma. You have this spindle cell proliferation of bland cells with eosinophilic cytoplasm with no significant cytologic atypia or increased mitotic activity. It's pretty infiltrative and has an epithelioid or a spindle cell phenotype, a kind of myogenic, pseudomyogenic morphology. One tip is about 50% of the cases, they may have intertumoral neutrophils, which is a clue for this diagnosis. But otherwise, one common misdiagnosis is cellular benign fibrous histiocytoma. It is diffusely positive for cytokeratin, hence the old name epithelioid sarcoma-like hemangioenthilioma, and is negative for CD34. CD31 can be variable. So every time we think about a vascular tumor, it's good to do at least 2 stains because one may be negative, the other one would be positive, but this tumor is consistently positive for ERG, and of course, INI is retained. 50% of the cases have SERPINE1 FOSB rearrangement, and approximately another 50% have the ACTB FOSB. And then there are very rare cases that they can have WWTR1, which is, as you show, that same fusion in epithelioid hemangiomas, cellular epithelioid hemangiomas, but can happen in pseudomyogenic hemangioenthiliomas. We described a new partner very recently, a CLTC, and of course an EGFL7 in a very aggressive pseudomyogenic hemangioenthilioma. But these are very rare reports so far. So all of them so far have a FOSB rearrangement, and of course the FOSB immunohistochemistry that I talked to you before in the epithelioid hemangioma chapter can actually be applied in pseudomyogenic hemangioenthilioma and works pretty well. This is a big study from Europe. You see about 96% of the cases, they actually were positive, and a couple of them that were not, they were decalcified specimens. And of course, they noticed epithelial hemangioma. That was before FOS or FOSB rearrangements were discovered in epithelial hemangioma. About 50% were positive. The specificity is not perfect. Nodular fasciitis, peripheral fasciitis can be positive, but of course, these entities will never be morphologic differential. Works pretty well. Again, a clear nuclear stain with a kind of blast non-specific cytoplasmic staining. It works in the majority of cases of pseudomyogenic hemangioenthilioma, to the extent that you don't, in a classic case, you don't need to do molecular. Epithelial hemangioenthilioma is a fully malignant, low-grade vascular neoplasm that shows primitive endothelial differentiation. It's important to differentiate that from angiosarcoma, specifically the high risk or the so-called malignant epithelial hemangioenthyliomas, because they behave less aggressive than epithelial angiosarcoma, which is a dreadful tumor to have. And this is a classic example. This is a vasculocentric pattern. However, I should note here that vasculocentrism of epithelial hemangioendothelioma in the skin is not as common as the deep counterparts. They have these epithelioid cells in a mixer-hyaline background arranged in seats, and they have intracytoplasmic blisters, which is basically primitive endothelial differentiation, and sometimes you can see red blood cells within these blisters. They are positive for vascular markers, and one caveat that I should mention is about 1/4 of them, they are positive for cytokeratins even in a diffuse manner. So that is a pitfall because you may diagnose as some kind of metastatic breast carcinoma, lobular carcinoma, and the like. The ordinary epithelial hemangioenthyliomas, the great majority of them have WWTR1 CAMTA1 fusion, and then a subset which is debatable if it should belong in the same entity, has YAP1 TFE3, which looks very different, have this voluminous eosinophilic cytoplasm and vasoformative areas where you will never see very well-developed vasoformative areas in ordinary epithelial hemangioenthelioma, which has more primitive endothelial differentiation. And there is a marker in the market for CAMTA1. It has been studied in epithelial hemangioenthyliomas, works very well. In this big study from Boston as well, 86% of the cases showed positivity, and one case of epithelial angiosarcoma was positive. The authors claim that retrospectively that probably was a high risk for malignant epithelial hemangioenthilioma. It has this clear, clean nuclear positivity of the neoplastic cells, and it doesn't stain the background non-neoplastic cells. However, I should mention here that recent genetics data have shown that there are other fusions in epithelial hemangioenthelioma so far with a propensity for cardiac involvement that is very new, and this may not stand the test of time, that they have WWR1 rearrangements with other partners. So presumably the CAMTA1 immunohistochemistry will not work in these cases, but so far no cutaneous case has been described with these kind of fusions. Fibroblastic or fibrohistiocytic tumors, the new kid on the block, EWSR1 SMAD-D3 fibroblastic tumor, was first described in April. Sites has this spindle cell proliferation of bland fibroblastic cells, can be very infiltrative, but the cells do not have any significant atypia, and they can be very infiltrative, as I said, resembling dermatofibrosarcoma protuberans. And usually, many times in the periphery is hypercellular, when more on the center, they have these hypocellular collagenized areas with calcifications sometimes. The very helpful stain is ERK. ERK stains a lot of different things, and this is another tumor to be added in the list, reducing its specificity. However, in the appropriate clinical morphology context, it can be very helpful. And it's quite interesting. It's not cross-reactivity, it's not non-specific, it's actually real protein overexpression. This is the mRNA data. Interestingly, this is the RNA unsupervised clustering, which clusters with calcifying aponeurotic fibroma, which shows FN1 fusions. And interestingly, the EWSR1 SMAD-D3 shows mRNA of FN1 really, really high, but also shows ERG mRNA really, really high, which subsequently is transcribed to protein. That's why we detected with immunohistochemistry much higher, even from angiosarcoma cases. This is the 3 green cases were all angiosarcoma cases. So ERG is not specific, but it doesn't stain only vascular tumors, and in the appropriate clinical morphologic context, in this particular scenario can actually be really helpful, and you don't even need to do molecular. And this is the largest series of a very recent paper by Dr. Billings and colleagues of a series of EWSR1 SMAD-D3 rearranged fibroblastic tumor. Epithelial fibrous histiocytoma, a classic case with epidermal color red and epithelioid cells, sometimes mononucleated, sometimes binucleated with perivascular accentuation. And of course, we know that they show ALK rearrangements and subsequently overexpression of the protein that is being detected by immunohistochemistry can be very helpful. Diffuse positivity, a couple of cases of epithelial fibrous histiocytoma with diffuse positivity for ALK. And of course, ALK can have different partners in many different tumors, including epithelial fibrous histiocytomas. The most common is SQSTM1, VCL is the other one, and other partners as well. It can be helpful. If it's classic, you don't even need to do it, but if it has some peculiar morphology, which can happen, like this kind of chondroblastoma-like, resembling the bone tumor that you see in the epiphyses of young individuals, namely chondroblastoma, can be actually helpful. And sometimes epithelial fibrous histiocytoma can be spindle cell predominant or almost exclusively spindle cell. So ALK can be helpful to make the appropriate diagnosis here, and shows here a couple of cases with diffuse ALK positivity and rearrangement detected by FISH. This is a nice review that we wrote a couple of years back if you want to read about epithelial fibrous histiocytoma and what is new so far. Of course, ALK is not specific. A lot of different entities have ALK rearrangements. One of them is the classic in the soft tissue world, inflammatory myofibroblastic tumor, which rarely, it's not common, it's very rare, but it can happen as a primary lesion on the skin. And it has this proliferation of myofibroblastic morphology, which cells that be diffusely positive for SMA in the Trump track pattern, and of course, diffusely positive for ALK, the ones that are ALK rearranged. Not all IMTs are ALK rearranged. And here is the FISH. Granular cell tumor, kind of a new thing. The ones that doesn't express S100, SOX10 is not of Svanian origin, the so-called non-neural granular cell tumor a subset of them can show ALK gene fusions. And this is another paper with 3 additional cases in JCP of non-neural granular cell tumor, which shows diffuse positivity for ALK. But of course, ALK, as I told you, is not specific and be positive in Merkel cell carcinoma, even in basal cell carcinomas. And this is a nice review about ALK in cutaneous malignancies that you may be interested in. NTRK rearranged spindle cell neoplasm, the relatively new kid on the block. NTRK fusions, they have been described in various neoplasms of various lineages, hematolymphoid, mesenchymal, melanoma, carcinoma, and it's very, very important. Why is that important? Here you see the percentage of cases of melanoma, sarcomas, and various tumors that have been described NTRK fusions. They're not that common in most of the tumors, but it's very important because we have a targeted treatment. And the first drug to be approved by FDA in 2018 was larotrectinib. Now there's a couple of others. And these patients actually respond to targeted therapy irrespectively of the histology agnostic, and they have a really good response. So that is really important in medical oncology the last few years. And there are stains for TRK A, B, or C, and there are a stain for PanTRK. There are two companies, Abcam and Ross Ventana, that developed the antibody. It works pretty well for carcinomas. It doesn't work very well for sarcomas if you apply the stain indiscriminately. But there are some histologic clues where change the pretest probability when a tumor can have an NTRK fusion. So in these cases, if you apply pan-TRK immunohistochemistry, you may actually get a better sensitivity and specificity. And of course, the cases that are positive, they always need to be confirmed molecularly. And of course, there will be cases that are going to be missed with immuno. And it really matters. This is the case that we had a few years back. This historically had been diagnosed as fibrosarcomatous DFSP. This was a 2012 specimen, has this proliferation in a honeycomb fashion of the fat with blunt cells with diffuse strong positivity for CD34. And in the background, it had this fibrosarcomatous proliferation with increased mitotic activity and loss of CD34. And it was reasonably diagnosed as FSDFSP. It had positive margins. The patient did not come back for re-excision, and after a year had a local recurrence. It shows like a fibrosarcomatous proliferation, and that TRK was done after a few years, and I'll tell you what we found. So I had a local recurrence in 2013, and then I got the specimen in 2016, and that is the metastasis in the groin. The primary lesion was on the back, and has this spindle cell with spindle to stellate cell proliferation in a mixed background. I found it quite peculiar, so I wanted to prove that this was indeed a fibrosarcomatous DFSP, and I couldn't. It was negative for fish, PDGFB, etc. So I did NGS, and we discovered EML4 NTRK3 fusion, and then the subsequent TRK, pan-TRK immuno was positive, and that's important. And of course, we published that case, was the first case in the skin at that time. It was important because the patient has now a metastatic sarcoma, where if it was the diagnosis, it was FSDFSP, the targeted therapy would be imatinib, where presumably will not work in this case, where here you can give larotrectinib or other TRK inhibitors, and presumably can work in the significant percentage of patients. Neural tumors, cutaneous malignant peripheral nerve state tumor, defined as mpnsd. Now, if mpnsd is primary superficial mpnsd, is rare in the skin. If you're trying to make that diagnosis, 90% would be wrong. It's going to be melanoma. But there are primary mpnsds, genuine primary mpnsds, and in contrast to their deep soft tissue and visceral counterparts, they are rarely associated with NF1. And there are two subtypes, the conventional spindle and the epithelioid. And I want to talk about the epithelioid because the chances is if you're going to see an mpnsd in your career, it's going to be the epithelioid variant, because that's more common in the superficial sites. Here's a big paper, so about 70% were actually dermal and subcutaneous. And this is a case of epithelioid mpnsd, multilobulated, kind of uniform, with epithelioid cells with vesicular chromatin pattern and prominent nucleolus and increased mitotic activity. And they are diffusely positive for S100 protein, but they are negative for other melanocytic markers. But of course, melanoma will be in the diagnosis. It will be very unusual for this epithelioid phenotype to be completely negative for melanocytic markers. But as we all know, melanomas can do everything. But one very helpful stain is to do INI1. INI1 protein expression is lost in 2/3 of epithelioid mpnsd, where there's no a single melanoma has been described to show loss of INI protein expression. The melanomas can show INI mutations. That's very well described, but INI protein loss so far has been described. So it can be very helpful in your differential of epithelioid mpnsd versus melanoma. But I&I loss, the new thing is, can be seen in epithelial schwannomas. And epithelial schwannomas, you're going to see them as a dermatopathologist because they are very, very common superficially. Here, 98% were dermal and subcutaneous in this very big study from Boston and from Emory. This is a typical case of epithelial schwannoma, has this perineural layer surrounding, and then have these epithelial cells that they don't look as atypical of epithelial mpnsd. They don't have prominent nucleoli, great mitotic activity, etc. But of course, you can have degenerative atypia that is common in other schwannomas as well. But very rarely you can have epithelial mpnsds arising in the background of epithelial schwannomas. And you see here a case of epithelial mpnsd, which looks very atypical and with true atypia, not this kind of degenerative atypia in the background of epithelial schwannoma. And of course, you're going to do S100, so that will be positive, but I&I is not going to help you because I&I is lost in epithelial mpnsd and epithelial schwannoma. So if your differential is between epithelial schwannoma versus epithelial mpnsd, benign versus malignant, or epithelial mpnsd arising in the background of epithelial schwannoma, I&I is not going to help you because the new thing is that epithelial schwannomas, they show I&I loss as well. It's total morphology. But if your diagnosis is malignant versus malignant, melanoma versus epithelial mpnsd, then I&I can be extremely helpful. Thank you very much. And this is my contact info, and this is the campus of Dartmouth University. And again, thank you for the invitation.